every day. Hospitals, EMS services, and lay people across the globe use Zoll products to save lives.
I want to thank all of you all to come to attend this session. And while preparing my topic on the diagnosis of acute coronary syndrome with high-sensitive troponin, is 2 hours ED rule out guideline of reality, I found this very interesting article published in the Annals of Emergency Medicine, and again by the very famous Christian Muller, on 1 hour rule out criteria with high-sensitive troponin. And so my talk will be based on these articles, and then I will sort of supplement some of the facts that the audience may want to know. Next. Okay, and for this study, the inclusion criteria is that the patient presented to ED with symptoms suggestive of AMI. And this is a very subjective inclusion, but however, I think all the cardiac markers study, all the inclusion criteria are like that. And onset or maximum of chest discomfort or pain within the previous 6 hours, and somehow they include a small proportion of STEMI patients. You know, in STEMI, the diagnosis is that of ECG. And the first study, blood draw must be performed within 45 minutes of presentation to the ED. And the exclusion, renal failure required hemodialysis. So the conclusion of this study may not apply to a patient with renal failure on dialysis. And they do an additional blood draw in 1 hour, 2 hours, and 4 to 14 hours. And for the blood drawn, they have a local standard conventional troponin assay. And the high-sensitive T and I are not available to the treating physician. So the treating physician make the diagnosis based on the conventional troponin assay that they are using. And the endpoint is 30 days AMI, primary endpoint. And this endpoint is adjudicated by 2 independent cardiologists, okay, and then they review the records from ED presentation until 30 days follow-up. And this include high-sensitive troponin I, but not T. Include high-sensitive troponin I and local troponin, conventional troponin. And the secondary endpoint is a mortality at 30 days and 1 year. And this is the definition of myocardial infarction. They use the cutoff point as a 99 percentile of population of 40 and for the high-sensitive troponin I, and the increase and decrease is 20. This is the universal definition of myocardial infarction. So in order to diagnose AMI, now we require a troponin that is above the 99 percentile. Okay, together with at least one of the following: the symptoms, ECG changes, okay, and or the presence of regional wall infarction by imaging. And so this is for the study, this is the conventional troponin, and this is a high-sensitive troponin I and high-sensitive troponin T. And there's a limit of detection for the levels, and there's less than 10% coefficient variation, 99 percentile of healthy population, and there's ROC. So it's a very complicated thing. So I'm trying to explain what does it mean. Okay, so the limit of detection is that, you know, the amount that the blood test can, I mean the lab can, the method can detect. So you see, for the conventional troponin T, the limit of detection is 10. Okay. However, 99 percentile of the healthy population has absence of undetected level of troponin, so it's less than 10 or less than 0.01. It depends on what unit you're using, and then with the event of high sensitive troponin, we have to times 1,000. And then, okay, what is different between sensitive what is different between troponin I and troponin T? Basically, troponin T is patented, so there's only one type of troponin T available in the lab. However, troponin I, there are various various labs that is producing troponin I, and the cutoff point could be different. Okay, so this inventor of troponin T is a German Dr. Carter's from Heidelberg of Germany. And okay, so upper limit of normal set at 99 percentile of the normal healthy population, and the lower limit is however, in the lab, the lower detection limit is 10% of coefficient of variation. Okay, that means if it's below 10%, the lower detection limit of 10% coefficient of variation, the result is not accurate. So in the conventional troponin, the 10% coefficient is higher than the 10% of the population. So usually we use 10% coefficient of variation. And however, the study think that we should use the 99 percentile cutoff point because that will include more patients that should in the high-risk group. And so, example, this is a conventional troponin T, this is high-sensitive troponin T, and it is not the same, okay? So in conventional troponin T, 0.01, however, if you measure the same blood in the high-sensitive troponin T, it's 0.33. Right, so again, it's not interchangeable, and then the calibration is by this equation. So 0.03 is the 10% CV. So if you use high-sensitive troponin, it should be around 54. And this is the first study of high-sensitive troponin T that was published in, I think, New England Journal of Medicine, and they included patient symptoms 12 hours before presentation. Again, they exclude patient on dialysis, and the endpoint is 60 days AMI, unstable angina, and sudden cardiac death. And this is the comparison between high-sensitive troponin T and the conventional troponin. And this shows that high-sensitive troponin T detect the endpoint much earlier, and also is more sensitive than the conventional troponin. And again, this study shows that if you use for high-sensitive troponin, if you use the 99 percentile plus the delta changes, and they recommend they found that the delta change should be half of that of a 99 percentile value. Either you use these two in addition, either 1 hour or 2 hours, you found that the ROC curve sort of improved tremendously. And now we come back to this study again, right? So they educated the endpoints, and then which is 30 days AMI, and then they used the high-sensitive troponin T to derive this algorithm. Okay, so the rule in and the rule out. So they don't do it in real time, but they just use it, do it. After the patient has discharged and all that. So it's not a real-time real-time algorithm. And those who rule in with high-sensitive troponin T more than 52 and delta changes more than 5 is 75% predictive value. So this is very good because I think if you tell your cardiologist, 175% had AMI, I think they will take the patient and probably bring the patient to a cath lab because 3 out of 4 is correct. Okay, so I think we can do this part no problem. And the cutoff point is 52. And for the rule out, the negative predictive value is 99.1%. It is good enough or not? That means 0.9% of them they will rule out incorrectly. So if you see 1,000 patients, 9 patients will rule out incorrectly. So I think it's quite a big problem for the emergency physician. Although for the researcher, less than 1%, So and in this group of population, 70% of the cohort have AMI. And unstable angina is another 13%. And we also have cardiac symptoms, but not CAD for 9%. So I'm going to talk about the rule out. What is the problem with rule out of 0.9%? So it is not, if you look at the subgroup, those with history of CAD, the negative predictive value may be less than 99%. And those 62 years old older may be less than 99%. Although in average it's 99.1%. So it depends on the patients as well. And also these are the patients which are incorrectly ruled out by the 1 hour algorithm, the high sensitive troponin 1 hour algorithm. And most of them, if you keep them long enough, the troponin will elevate it to the high cutoff value. And And personally, I think if you keep the patient for another few more hours, it's not a problem. Anyway, I don't think there's that. Overcrowded in the emergency department is not because we keep chest pain for more than 2 hours. Okay, it's for other reasons, because the patient cannot get a bed in the inpatient setting. So how to minimize this group of incorrectly ruled out? This is our study using conventional troponin. Those who have normal conventional troponin T using 10% CV value, 1 year follow-up with sort of a severe coronary artery disease is that of around 6%. Of course, cardiac death is very low. And we have to rely on a stress test, stress nuclear scan and all that. And which patient go to this stress test, because this is only about 5-6%. Again, we don't have a formula for it. I mean, you can use the risk score that I will talk about it later on. And this is a stress image, and the bottom is a stress image. The top is a stress image, and the bottom is a rest image. And you can see this patient has normal troponin, normal ECG, and has severe coronary artery disease. Show at the images, and also. No matter how low you set your troponin value, you always have this thing called unstable angina. All right, and then troponin you can't rule out aortic dissection, which can be fatal, pulmonary embolism, or aortic stenosis. So that's our problem. Okay, and if you really suspect aortic dissection, and the patient look relatively well, you can do a sort of a D-dimer, all right, if a D-dimer is normal, then yeah, most likely the patient will not have aortic dissection. Again, aortic dissection is very difficult to diagnose. And for those which are ruled out, okay, and you can see, they have 0.1, 30-day mortality was 0.1%, okay, and then again very low mortality over the past 1 year. But for those who are ruled in, again a higher mortality, and for them in the observation zone is very interesting, because the 30-day mortality is similar to that of the rule-out group. However, the 1 year mortality is similar to the rule-in group. So something is cooking there, So maybe we are missing the AMI, or they have AMI plus other thing, or they have AMI but we are not treating, so they have worse outcome, or maybe they have aortic dissection or whatever. It's equally fatal. So we really do not know. So there's this huge observation group. And also study also show that even general population more than 65-year-old, no prior heart failure, 16.6% of them have raised troponin, high sensitive troponin, more than the 99th percentile. And of course, there are false positive causes of non-ACS causes of troponin elevation, either non-cardiac injury or secondary cardiac ischemia. This is because of sepsis and all that, because of demand and supply. And some of these, the presentation could be similar to the acute coronary syndrome, like heart failure, both of them have breathlessness, pulmonary embolism, breathless, plus chest pain, and renal insufficiency. And on the other hand, the presentation of acute coronary syndrome can be varied. It can have epigastric pain, shoulder pain and all that. So life become very complicated. And then with all these things, I think maybe I shouldn't be emergency doctor or this well. and okay, why we choose the cutoff point as 13 or and 50, 52 for the study, and that because it's less than 14, the percentage of AMI is very, very small, and if more than 50, the percentage of AMI in the cohort become suddenly increase. All right, I think that's why they choose the cutoff point. Of course, the higher it is, the likelihood of AMI become higher. And very high troponin can only be AMI and myocarditis, okay? But low troponin, lower level of troponin, you can have other sort of pathology. And this is JC from this, he's undersecretary in the United States Department of Health, and he's also a very prominent cardiologist in Virginia. And he said troponin was great when it was a crappy assay. That means at that time, it's not very sensitive, but it's very specific. And now it's a good assay, it sucks. Because now there's a lot of false positive. And we, as a doctor, we have to think how to deal with it. And also you have to be careful. I mean, as for troponin or whatever test, this is a very good test, 99% sensitivity and 95% specificity. However, it depends also on the prevalence of disease. So if the prevalence of disease is very low, then the positive predictive value will be dropped. Like if the prevalence of disease is only 1%, the positive predictive value is only 17%. So there will be a lot of false positive. For example, this the real case. This 70-year-old lady, see a colon, palliative care, not drinking, not eating, and then nausea, vomiting. So came here, hypotensive, and then so in shock, right? It was dry, and then so very straightforward, right? We admit the patient. Then the resident come and tell me, say, but then the troponin is 0.07, so it's more than the cutoff value. So I said, go and call the cardiologist. And then he hesitant. He said, but the patient don't have chest pain, not breathless. So I asked him, I said, why you order troponin T in this patient? So now he give me more trouble. You want to use my license to tell you don't have to call the cardiologist. So, I mean, if the test is not indicated, don't order it, So this is and also we have type 2 AMI, this type 2 AMI. And some of the type 2 AMI are not that benign because the patient do have severe coronary artery disease, but present as sepsis, So the patient have elevated troponin T. So in fact, the patient have sepsis plus AMI. And of course, the cardiology don't like to take this group of patient. Okay, so this is the only slide that I'm going to show for renal patient on dialysis. If they have normal high sensitivity troponin, it's very good, okay? But 75% of them have elevated troponin, and they have poor outcome. But we don't know what to do. We don't know how to manage them. So this is our problem. Further research. So what about the 2 hours protocol? And there are a few interesting studies about troponin 2 hours, 2 hours troponin T plus plus rescore. So in this study they use sort of high sensitivity troponin T 2 hours plus a TIMI rescore more than 1, more than 2, and patient have no ECG change. So these are the TIMI score. You can read it in most textbooks. So if And this the outcome that they are doing, that they are using by 2 cardiologists, STEMI, non-STEMI, emergency vascularization, blah, 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 our standard endpoint. And then, so if you have a normal 0 and 2 hours troponin and your very low risk score, okay, you can exclude 30 days MACE, all right? However, the problem with this study is that they did not specify does the patient, and all the patient in this rule out. You can send home patient after 2 hours, but who came back for a stress test was not mentioned in this paper. Probably, again, it's a clinical decision. Okay, and then, so this is a very interesting randomized study done in the New Zealand Martin Tan and Louis Cullen group. Okay, so the standard care. So they do a troponin in 6-12 hours, and then follow-up investigation by discretion of the senior physician, and then encouraged to visit primary care. However, if they use a 0-2 hours protocol with a TIMI rescore 0, they can discharge. Okay, and they will come back for a stress test within 72 hours. So it's quite a lot of effort to organize this because everybody get a stress test. I think in the United States probably that's the current situation. And then for the 2 groups, there is no difference in adverse outcome. However, they found out that in a control arm, you need 20 hours to clear the same proportion of patient discharge as in the experimental arm, you only need 6 hours. So although this is a 2 hours protocol, but the patients still stay in the department for 6 hours. They have to wait, have to wait for a blood test result. So I think to strictly implement this 0-1, 0-2 hours is really very, very difficult. And as I said, the cause of ED overcrowded is not because the patient stay in a few extra hours in the ED. So this 1 to 2 hours rule out ACS protocol, is it for prime time? I would say maybe not, because in fact, in the study that was mentioned, they don't do it as a real time. Okay, in fact, the treating physician do not know what is the high sensitive troponin results, and we always have fear of unstable angina or aortic dissection, which have normal troponin level. And if the patient arrives at night, you cannot send the patient home, at 2 a.m. Put it this way. And we don't know, those rule out who should come back for mandatory stress test. And the observation zone, what are we going to do? Are we going to offer them a stress nuclear scan or CTA? For those who are working in, who's working in SGH? Okay, this slide is to show you that don't order CKMB on top of troponin, okay, because it is useless. From this chart, you know that, and there's no paper I know that shows that CKMB is more accurate than troponin in the diagnosis of acute coronary syndrome. Yeah, so in summary, CKMB are no longer required for diagnosis of AMI or ACS, and a single troponin result does not equal a diagnosis of, so you need clinical ECG as well as stress testing, and serial changes in troponin are essential for interpretation. And high-sensitive troponin assay may provide earlier diagnosis of AMI and further risk stratification. And beware of false negative result of cardiac marker test, AMI within 2 hours after symptom onset, unstable angina, aortic dissection, and PE. And thank you very much for your attention.
Thank you very much.